Good evening and welcome to Feet Forward, a special holiday version. We've kind of sandwiched this segment of Feet Forward after Thanksgiving but before Christmas. And we're actually the first day of Hanukkah today, isn't it?
It is.
Right? Happy Hanukkah to all of our Jewish viewers out there. With me today is Dr. Roland Tolliver. Am I pronouncing that correctly?
You are.
Dr. Tolliver is a podiatrist from Freeport, Illinois. And you've been in practice for about 25 years, and you're board certified in foot and ankle surgery since 1989, right?
Correct.
Okay. And where'd you go to school?
I went to Wayne State University, Detroit for undergrad, and I went to the Dr. William Shull College of Podiatric Medicine in Chicago, and did my surgical residency at Rush here in Chicago as well.
Rush University Medical Center, correct?
Yes.
Correct. Back then it was Rush Presbyterian St.
Rush
Luke's
Presbyterian
Medical
St.
Center.
Luke's, correct.
A little medical history for you folks out there. Tell me about your practice in Freeport and the kinds of patient demographics that you see, and what's some of the common foot care problems that you run into?
Well, we live in a fairly geriatric community. There are several extended care facilities as well as assisted living facilities, and the population tends to skew to the over 60 age group. So we do see a lot of primary care conditions with podiatry consisting of nail care, care of painful calluses and corns, bunions, hammer toes, but we see primarily a lot of diabetic foot care, wound care as management as well as preventive care.
Do you make any house calls for
I
your
do
patients?
actually. I just made one on Friday morning, I believe it was, the day after Thanksgiving.
People that follow this show might remember a couple years ago we had Dr. Contento on.
Yes.
And he actually does almost a majority of his practice is home visits, and Medicare does provide some coverage for that.
They do.
A lot of people don't know
Yes.
that, but that was an interesting revelation. And among the geriatric population, what are some of the biggest problems that you see in those people?
Well, there's been an ever-increasing number of patients with diabetes, and with diabetic patients, there's always going to be a need for podiatric services. Our biggest emphasis is on prevention. We want to prevent people from getting wounds, open sores, ingrown toenails, anything along those lines. And something that people may think is being innocuous as having a thick toenail, if it's in the wrong type of shoe and there's too much pressure, that could lead to a sore. And patients oftentimes with diabetes, unfortunately, they have something called diabetic peripheral neuropathy, which is where they lose the sensation to their feet, and sometimes all the way into the lower legs. And when the loss of sensation is there, they can continue to ambulate or walk about and not even realize that there's something wrong. One of the case scenarios that I oftentimes tell general audiences is I had a patient one time who walked around for almost 2 weeks with a jack in her shoe that her granddaughter had dropped into her shoe. And she did not come in finally until there was blood noted in the sock in the shoe because she had been walking on it, but her neuropathy was so bad that she could not feel her feet.
Wow. That's amazing. So you mentioned prevention. When do you start talking to your patients about that? Because oftentimes if you'll get a patient in with symptoms, it's too late to prevent it. You
Correct.
can prevent it from being acute, but at what point with your patients who are in their 30s, 40s, and 50s, when do you start talking to them, and what do you say to them that can help them prevent it down the road?
Well, the biggest thing right now is primarily education. We want to let the patient population know. We want to let the primary care physicians know. The endocrinologists already know. I mean, that's one of the first things that they will usually do is they will tell their patients, please take off your shoes and socks when you come into the room,
Right.
Because they want to check for the sensation to the feet. They want to look for any abnormalities. But oftentimes, and it's gotten so much better over the last 10 to 15 years, most of the primary care physicians, typically when the patient is diagnosed with diabetes anymore, they will say, I want you to go see a podiatrist. Sometimes there's nothing wrong. I mean, there are times when patients have diabetes and all we have to do is just kind of check things out, do a general assessment, just like if you'd go into your dentist twice a year for, for oral checkups, or optometrist, yearly for eye checkups. We encourage patients to see their podiatrist once or twice a year if they have diabetes and aren't having any real symptoms, just in order we can follow the progress, to make sure that there isn't nothing going on that would be detrimental to their health. What we do look at, though, is when we have patients that already have an existing problem, in those cases, then we follow them much more closely. I have some patients that come in once a week for management of, say, like an open wound until we can get that wound healed, or if there's something else going on. And infections are a big problem as well.
Mm-hmm. What are some of the more acute ramifications of sort of unchecked or unprevented diabetes in patients that come through your office at times?
Well, the ones that come through our office, probably the most dramatic would be something that's called Charcot-arthropathy. And that is where a patient with diabetes and neuropathy who cannot feel their feet has some type of, oftentimes just minor trauma. And what will happen is it will actually start to cause destruction of the joints in the middle of the foot. Mm. When that occurs, these are usually our type 1 diabetics. And, and I know there's been a big write-up in the paper recently about the whole idea between type 1 and type 2. Right. Is type 2 really diabetes? And, yes, they are both diabetes, and they can both actually manifest certain conditions that will develop, such as diabetic neuropathy, diabetic nephropathy, which is kidney disease, and diabetic retinopathy, which is eye disease.
So from a podiatrist point of view, there's no difference really between 1 and 2, is there?
Typically there isn't, but because a lot of patients with type 2 will eventually develop type 1 if it continues to go uncontrolled. But the biggest thing is that we run into this cycle, kind of a catch-22 situation, because the doctor tells the patient, well, if you diet and exercise, we can get your blood sugar back under better control. Right. But then they start to diet and exercise, and most people do what I call the too much too soon syndrome, where they try to go out and, well, the doctor said to exercise, so they go out and they walk 5 miles the first time in a pair of wrong-fitting shoes, and they end up with a stress fracture. So now they can't walk, which then further complicates the problem of the diabetes, because they can't get the exercise in. So they sit around and feel sorry and eat.
That's got to be a difficult sort of situation for a podiatrist to be in. What do you advise your patients who you can sort of see down the road that they might be at risk for developing that? How do you ease them into that situation?
Well, number one, it's very gently.
That's the way I work out too.
Choosing words wisely.
Right.
But there's a lot of counseling involved. I mean, people don't realize it, and it's funny because one of the things about podiatry that I think a lot of people don't take into account is that we are one of the few professions where we can sit and actually take care of a patient and communicate with them at the same time. Oftentimes the visits may be 10, 15, 20 minutes, in general.
Right.
A new patient could be longer. But even while we're working, we can still be communicating with the patient. And so while we're doing that, some of the factors that we really want to convey to them are, number one, diet and exercise are critical. This is a team approach. We are trying to work with their primary care physician, with their endocrinologist, sometimes with their nephrologist. So I have a lot of patients that are on dialysis. And that creates an entire different spectrum of complications that we can see.
Are you sending reports back to the
We
primary care doctor?
We send reports back to the doctors, especially on the new patient visit. If it's just a continuing care situation where the patient's coming in every 2 to 3 months to make sure that their calluses are trimmed up and their nails are done properly, in those situations, it's not necessary to constantly, communicate. But if something would change, then yes, definitely. And oftentimes it's a phone call saying, hey, this is what's going on. We need to either admit this patient or we need to, put the patient on this medication, for, say, an antibiotic for infection or something.
Yeah. I know that one of the sometimes when I try to call your office, they say that you're in surgery, and usually when I hear that, I kind of cringe because that often means that you're doing an amputation or working on that kind of case. But that's sort of the end.
That's the very end spectrum.
Of the road for
And the APMA recently did sponsor a study by Thomson Reuters that showed that there's a 24%, if I'm not mistaken in my numbers, decrease in hospitalizations for patients who see a podiatrist with diabetes, to prevent them from having to go in for things like infection, for the necessity for amputation. There are over, I believe it's over 82,000 amputations a year, non-traumatic amputations that didn't arise because of injury. And the majority of those are coming about because of uncontrolled diabetes in patients with peripheral neuropathy and or peripheral vascular disease. And oftentimes people think that because they have neuropathy that they have to have vascular disease as well. And in our geriatric population, oftentimes that is true. But in our younger patient population, say those in their, that develop juvenile onset diabetes, or those that have type 1 from the age of like 20s to 30s, they will develop neuropathy oftentimes with excellent circulation still present. And those are the patients that oftentimes run the greatest risk for some of our complications, because they still think they're young and healthy, they still are very active, and there are times when something as simple as an ingrown toenail or a blister will go unchecked for a week or two before they come in to see us, because of the fact that they can't feel it. But because the circulation is still flowing, then they can end up into with the problems like I was telling you about earlier with the Charcot-arthropathy,
Right.
and dissolution of and breakdown of the bone tissue. So
there's been a lot of discussion about diabetes. In fact, November was National Diabetes Awareness Month.
Correct.
We just came out of that. So there's probably an uptick in the awareness of people who are at risk for diabetes. But I think it's probably would be helpful to our audience to go over some of the risk factors for diabetes, since we're talking about prevention. So tell the audience about who tends to be at greater risk for diabetes, and then ways that those people can reduce their risk.
Well, type 1 diabetes, especially juvenile onset or early onset diabetes, I don't think there really is any type of prevention that you can do at this stage. It's the pancreas is not functioning properly, you're not producing enough insulin, the body,
Right.
it's oftentimes hereditary as well.
Yeah.
There's a hereditary component anyways.
Sure.
What actually triggers it is still up for debate. Type 2 diabetes, on the other hand, for the majority of the people, it's lifestyle. Too much fast food, not enough exercise, too much time in front of the television, although tonight's audience, you're forgiven.
Special dispensation.
Yes, that's right. And
The CAN TV audience.
but we've got the opportunity to educate. We are looking at, just even a year ago, they thought that by the year 2050 that 1/3 of the population would have diabetes. They've now pushed that up to 50% of the population, they believe, by that stage will have diabetes. And it's coming about for a multitude of factors. I mean, and a lot of it is just our lifestyle. I mean, we're living longer, so there's greater opportunity that way as well,
Yeah.
which is the plus side.
Right.
But on the downside, we're not as active in general. I mean, we see our runners, we see we see that population as well, and they're not the ones that are typically prone to this. But on the other hand, you see patients that have worked hard all their life, and they retire at 65 and aren't quite sure what to do anymore. And sometimes that lifestyle will then take over, and we have a lot of patients that first time they're diagnosed with diabetes, they're 70, 75 years old. So I think the key thing is it's the whole adage of everything in moderation. That there still needs to be some form of exercise, whether you're getting out and doing it on your own or with a group.
Right.
There's a whole big study right now going on where they showed that diet and exercise in a group setting has actually helped to reduce the level of diabetes in patients.
Why is a group setting important?
Well, I think sometimes it's just the mindset. A lot of times it's hard to do something on your own.
Sure.
And if you have a group setting, you're more inclined to feel the accountability. That's why things like Weight Watchers work so well, because you have accountability, and you have a support group, and you have somebody you can turn to. I mean, any type of 12-step program is the same way.
Right.
This is just maybe a 12-step program to keep moving beyond 12 steps and get the exercise in.
This is actually a good segue to talk a little bit about, give a little plug to a few Chicago area podiatrists who are going to take time out of their day on Friday afternoon to go to an elementary school in the south side of Chicago and spend 2 hours talking to the kids there about the importance of exercise, shoe selection, not sitting in front of the TV. They're going to give out pedometers and foot care tips to the kids there. And we think it's sort of starting out as a pilot program, but we hope that through the partnership with the Chicago Public Schools, they'll be able to expand it and have more podiatrists volunteer for the program, go into the schools, get the kids early, and get a positive message about exercise and as a way to prevent things early on. Speaking of kids and sort of kid-like sort of campaigns, the National Association, the American Podiatric Medical Association, every year runs a program that I know you're very familiar with called Knock Your Socks Off.
Correct.
And I want you to talk a little bit about that and tell the viewers why that's important and sort of what are the positive sort of consequences of carrying that kind of program out too.
Well, the Knock Your Socks Off program primarily has been instituted in in a campaign fashion in order to help to encourage people, even when they go to their primary care physician, to encourage them to have their feet checked. Most people will go to their primary care first and then to the podiatrist secondary, although we're finding more and more that, as awareness becomes greater, that people will come directly to the podiatrist for, first check when they find out they have diabetes.
Right.
But the whole point of the campaign is the fact that, if you don't check it, you don't know that it's there. One of the things that tends to happen with feet in general is that we get up in the morning, we take our shower, bath, whatever, we get ready for work or school, we put our socks and shoes on. We don't think about our feet again until we take our socks and shoes off at the end of the night and get ready for bed.
Yeah.
In between time, you have to think of all the steps that those feet are taking, and imagine every step that you take is 1.5 times your body weight of force on your heel or your feet. So when you do that, if you think of the thousands of steps that you take a day, we encourage 10,000 steps a day, for good health, is that you're putting all that extra, pressure on there. So during the day when we're not thinking about it because we're busy, we're occupied, we've got, the telephone ringing, we're on the computer, we're at work, we don't necessarily think about them unless our feet hurt.
Yeah.
So one of the things we need to really encourage is that, check your feet in the morning. Before you put your shoes on, check your feet at night when you take your shoes off. If you can't see your feet, have somebody else check them for you if at all possible.
And what should people look for?
They should look for areas of irritation, like blisters, any areas of redness, ingrown toenails. They should look for any deformities of the foot, such as contractures of the toes, hammer toes, bunions. You want to look for any calluses, any areas that there may be a little bit of even like bleeding underneath the skin, like a blood blister would be. One of the big things is changes in the toenails. People don't often think about that. But, if you can catch, like, say, a fungus-infected nail early on, it's a lot easier to treat than, if you wait until it gets to be, much thicker and embedded into that tissue.
And most people are treated at a primary care setting on the medical side, certainly.
Correct.
So if primary care physicians will do, this
they do
more
kind of
often.
and they're the gatekeepers for a lot of the healthcare. Whether they're sending you over for your colonoscopy or to have your ears checked, they would be sending you off to see for foot care as well.
And I'm increasingly seeing the posters on the other side of the door.
Correct.
Urging people to take their shoes off too.
My own physician has the same thing, which I'm very happy for. So
you delivered that poster personally, though, didn't you?
No, actually, they were good about that. So
that's impressive.
So, but it's as we talked about earlier, it's a team approach, and we have to have both sides of the equation or multiple sides of the equation depending on what conditions are going on. If you have somebody on dialysis that sees the nephrologist regularly, we have to communicate with them if something is going on as far as infection or wound, ulcer.
Sure.
And it's the same thing with the primary care physicians. They need to inform us if they see something and they think the patient needs to be treated, or if it's an early onset of diabetes or they've just been recently diagnosed, get them over to see us. I mean, we have a pretty extensive neurologic examination that we can do. We watch the way they walk. And one of the primary things that I think often gets overlooked is that when patients come in, I see all types of shoes that come in with them.
Sure.
And it's a lot of times they're worn down and says, well, doc, these are comfortable because they've worn them for 4 years.
Right. Yeah.
And shoes can be one of the major sources of a problem. There's another story of, and I don't mean to be anecdotal, but I had a lady that had very severe diabetes. She went into her local shoe store for shoes, and a young salesman, probably working on commission would be my guess, sold her a pair of shoes that said, oh, don't worry, you'll stretch it. These will stretch with your feet. The lady ended up losing both of her legs amputations because of the fact that the shoes were so tight that they caused blisters. The blisters became infected, ulcerated, and it all because of the fact that the shoes were ill-fitting. Medicare does run a program. It's the diabetic shoe program, where podiatrists, if they choose to participate, and then some other podorthists and other services. I think Waxburg's here in Chicago is an excellent resource as well, where they will actually fit allow the patient to be fitted for shoes that are considered to be extra depth, that will accommodate for a lot of different foot deformities, and there's multiple selections. I mean, hundreds of shoes to choose from sometimes. And insoles that will go into the shoes that will then accommodate any like lesions that might be present on the bottom of the foot, or just to give them that extra support that they might need. In certain cases, custom-made shoes need to be made because of the fact that there might be such severe deformities that you have to fit the shoe to the foot rather than the foot fitting to the shoe, because it's much and we always tell patients, I mean, diabetic patients, any patient, a lot of times is they're always afraid to hear the word surgery.
Sure.
Sometimes it's necessary. I mean, sometimes surgery can actually be very helpful in preventing further complications from occurring if the patient is healthy enough to have it. But it's always easier to operate on a shoe than it is to operate on a foot. So we want to make sure that we get the patient into the proper fitting shoes, get them into something that's going to accommodate any type of deformities, get them into something that will accommodate for pressure spots. And that's one of the things you'd asked about earlier as far as, what should you look for, as far as prevention.
Right.
It's been shown that if an area heats up too much, say like somebody goes to the mall, they're wearing a pair of moccasins and they walk the mall Christmas shopping for 3 hours. Well, that constant friction and irritation leads to an increased heat of the tissue, and that increased heat of the tissue causes inflammation, and that's what eventually can lead to the skin breaking down and sores forming. I've got a number of patients that have learned that very well, and I've got some that no matter what we've done and gotten ulcers healed up, that they still haven't learned that lesson. So we need to, constantly promote that, and the fact that, you can't go running outside barefoot and expect, something not to happen. You really need to be always in a preventive type of mode with diabetes, and especially the patients that have the neuropathy. So.
We've only got about 3 minutes left for the show, and I want to make sure everyone understands that they can find a podiatrist near them by going to the IPMA website. The address is right behind us. That's ipma.net. There's also an 800 number on the website. You click on the Find a Physician button, and you punch in your zip code, and you'll get 2 or 3 podiatrists near you.
Correct.
They're all IPMA members, and I guess the question I have about that Medicare program that you're mentioning is, can people find out about that program through virtually any podiatrist, or is there a special list of providers that are participating?
It has to be a podiatrist that has gone through, they have to sign up for what's called a durable medical equipment program. Okay, so DME is commonly known. And if they are certified through that and are licensed to be able to provide these the shoes, then they can. We're more along the lines of actually a provider and not a supplier. We don't carry, there are a few podiatrists actually do have shoe stores or shoe locations, podorthos type of shops right next to their office. That's few and far between, but most of us actually work with certified labs that can provide the shoes for us and either fabricate the insoles or provide insoles that can be heat molded that then can be fitted to the patient's foot and right in the office.
Does the Medicare website have a list of these providers?
I do not know if they do or not. But you can contact your podiatrist. The IPMA might have information on that. But the best thing is to find out. And if your podiatrist doesn't have this option offered for you, they should know a podorthist or a orthotic prosthetic lab that can provide it for you.
Okay. We've got just a minute left in the show. Give us some, last minute tip that kind of sums up, the message about diabetes prevention, so we can sort of take these people out into the holiday period with a positive, uplifting note from the folks at Feet Forward.
Well, no matter what we do on our end, you have to take care of your end as well. And that's, moderation in eating and exercise and making sure that, you're keeping your blood sugar under control. Because I can do the best job I can possibly do, or any podiatrist can do what they can do best as far as managing the corns, the calluses, the ulcers. But if the blood sugar isn't under control on a consistent basis, it is setting the person up for failure with their feet or their kidneys or their eyes. That's the best advice that we can give you. And it's, that team approach comes into play there, where you have to work with your diabetologist or endocrinologist or primary care physician to keep that blood sugar under control, and we will do our best to keep you on your feet.
Great. Well, thanks a lot, Dr. Tolliver. Appreciate you coming on. Happy holidays to everybody, and we will see you after the first of the year.
Thank you, Chris.